The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety. This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hey everybody, Eric back with you. Today I'm going to do a podcast and I'm going to focus on evidence-based practice. We're going to do 3 different podcasts related to current, evidence, research-based evidence, a retrospective look specifically to this podcast that was published in Respiratory Care Journal, June of 2016, volume 61, issue number 6. And the title is, should a tidal volume of 6 mils per kilo be used in all of our patients? If you've listened to the podcast for any length of time, you've read our ventilator book, you've come to our review courses, you know that I'm a prescriber of that thought process. So let's look at the evidence-based kind of outlook. And this study is phenomenal. I read this again. We were just recently on vacation in Puerto Rico. Currently in Hawaii right now. We're kind of having a nasty day outside, so I thought I would record this podcast. And a respiratory therapist named John Davies and his colleagues looked at this, and I thought it was a very well done study. It's kind of a longer read at 17 pages, but again, I thought it was phenomenal, and it really looks at all the evidence that's ever been published on mechanical ventilation and tidal volume selection. What's the best range, and what does the evidence say? So let's jump in. The premise that one prescription is good for all patients in all conditions on its own is difficult to sustain. I think it's impossible that one size fits all, right? We can't have that mindset. And that such a decision are so small in comparison with the benefits that it warrants a blanket application. So what I'm trying to say is we can't have that blanket application that one size fits all. There are a difference in all of our lung characteristics, our disease process, our compliance, and to say that all patients need a blanket 6 mils per kilo, I do think is the wrong approach. If we continue, it's been shown that mechanical ventilation by itself can cause lung injury. We know that this affects outcomes. Ventilator-induced lung injury is associated with high tidal volumes in lungs afflicted with ARDS. But the question is, do high tidal volumes have the same effect on normal lungs as they do on injured lungs or patients that are already suffering from ARDS? And I think that's the big question. That's the question I get all the time. Why are we using a lung protective strategy on a patient that doesn't have acute lung injury or ARDS? We know that the ARGNet study in 2000 looked at this specific kind of outlook, and they kind of questioned how medicine had been practiced related to respiratory care for all those previous years. And we know that they looked at that and they said, why are we delivering tidal volumes that are 10 to 15 mils per kilo when our normal physiology, most adults, we all breathe at about 6 mils per kilo. So really 400 to 600 mils per breath is going to be probably pretty standard. But it wasn't uncommon for patients to have tidal volumes at 10 to 15 mils per kilo based solely on a plateau pressure. If the respiratory therapist could get a tidal volume of 1,200 mils and the plateau pressure didn't exceed 30 centimeters of water, then that was all right. So I think many clinicians believe that a tidal volume strategy of 6 mils per kilo of ideal body weight should be a standard practice. And it's based on that ARGNet study done in 2000. There's a growing body of evidence related to this issue, and I think the debate is valid. So in this paper, they took a pro versus con perspective. So I'm going to highlight different aspects of the pro. I'm going to highlight different aspects of the con and kind of summarize it. Again, I'm going to put this in the show notes. I want you to read this, make your own kind of determination, and I'll kind of give you my thoughts as I move through this. I think, again, we have to always be objective when we look at our practice. We have to be willing to change. That's very, very important. So let's start. So ventilation to patients who do not have ARDS, kind of how do we deal with that? Although mechanical ventilation strategies are slowly gravitating towards the use of lung protective ventilation, many clinicians have not adopted the practice. I see this all the time, right? I know that there are review classes out there right now, and I'm going to say right up front, this is absolutely the wrong approach to teach, that are still teaching to give tidal volumes of 8 to 10 mils per kilo. That is so out of date, and we have to remember that that is not current practice. 6 to 8 mils per kilo, that is current practice. Maybe exceeding that in certain circumstances, that's current practice. But a blanket statement of 8 to 10 mils per kilo, that is long changed. When we think about this, the biophysical injury in ARDS or the lungs related to ARDS, why does that happen? That happens because of overdistension. It happens by overdistension of recruited alveoli, right? That was the whole point of why they delivered such high tidal volumes, because they didn't want collapse. They wanted to recruit as many alveoli as possible. But we also have to remember that that causes direct cell damage. It causes what's called cyclic opening and closing of the alveoli, and that causes injury. We know that causes surfactant loss, or the loss of surfactant function. So shortly after the ARDS, the ARDSNet study, I should say, in 2000, Gostick et al. Conducted a retrospective study of 332 medical surgical subjects receiving mechanical ventilation for greater than 48 hours who did not have acute lung injury at the onset of mechanical ventilation. They found that 80 subjects, so 24% of them, developed acute lung injury within the first 5 days, and on average within the first 3 days. They concluded that there exist two important risk factors for development of acute lung injury. Number one, large tidal volume values, and number two, it was administration of blood products. Interesting. So these are patients post ARDSNet study in 2000 that had no history of acute lung injury or ARDS, that were put on mechanical ventilation, and the number one thing was high tidal volumes that they identified as started that acute lung injury. Macia et al. Conducted a prospective observational study of 82 mechanically ventilated subjects with severe brain injury, but were otherwise had healthy lungs. In this population, 18 subjects, or 22%, developed acute lung injury. The subjects with acute lung injury were initially ventilated with significantly higher tidal volumes at 10.4 mils per kilo compared with subjects without acute lung injury. The risk factors for acute lung injury were high tidal volume, breathing frequency, and expiratory minute volume. Later, the same group examined 118 patients who were deemed potentially organ donors. This was a randomized controlled trial in 12 European ICUs that compared conventional ventilation, so tidal volumes of 10 to 12 mils per kilo, and 3 to 5 centimeters of water of PEEP, with protective ventilation of 6 to 8 mils per kilo and 8 to 10 centimeters of water of PEEP. So again, they went the old way, 10 to 12, low PEEP, and they compared that with the new way of 6 to 8 and higher PEEPs. The results revealed a dramatic increase in the number of eligible lung donors, 54% versus only 27% in the conventional group, suggesting that lower tidal volume values may have a role in lung protection. In a large prospective randomized controlled trial, Determan et al. Compared the use of 6 mils per kilo versus 10 mils per kilo in 150 mechanically ventilated ICU patients. The trial was stopped early because the rate of lung injury development was 13.5% in the 10 to 12 mil per kilo group versus only 2.6% in the 6 mils per kilo group. That's a big difference, guys. The investigators also found significantly higher lavage fluid cytokine levels in the 10 to 12 mil per kilo group. Also, the 6 mil per kilo ideal body weight group did not require any additional sedation or hemodynamic support. So very powerful. In 2012, Serpa, Nato et al. Performed a meta-analysis of 20 subjects, or I should say a meta-analysis of 20 studies, 15 of which were randomized controlled trials. So we had a total amount of patients of 2,822 subjects receiving mechanical ventilation who did not have ARDS initially. So all these patients had no acute lung injury, no ARDS, pretty large sample size. They found evidence that the use of lower tidal volumes was associated with a lower risk of developing ARDS, lower mortality rate, fewer pulmonary infections, and a shorter hospital stay. The same group followed up with a patient-specific meta-analysis of mechanically ventilated subjects without ARDS at the onset of ventilation. The meta-analysis included 5 randomized controlled trials and 5 observational studies. The subjects were stratified into 3 groups. So the first group was patients with tidal volumes less than 6 mils per kilo, ideal body weight. Number 2, tidal volumes of 6 to 10 mils per kilo, ideal body weight. And group 3 were tidal volumes greater than 10 mils per kilo, ideal body weight. The findings of the study were that the tidal volume values of less than 6 mils per kilo of ideal body weight were associated with more subjects breathing without assistance at day 28 and more ventilator-free days. Again, very powerful. The thing I loved about this study when I read it, guys, is that there are so many examples. We're not looking at this from one perspective, right? We've often just always quoted the ArchNet study of 2000. There are so many studies out there that have shown benefit. Here's kind of another aspect. The evidence presented above is suggestive of the fact that larger tidal volumes lead to increased pulmonary inflammatory mediators, pulmonary vasoconstriction, pulmonary compromise, and ICU patients who do not initially present with ARDS. So that is a big statement, that we do have complete control of how we manage our patients, and that if we deliver the wrong care, and we see this all the time, we see medicine changing significantly over the last 5 years in a lot of different things that we do. We need to do things that are more physiologic. We need to understand that more is not better all the time. So now let's look at this from a different perspective. And that different perspective is, what is kind of the con aspect? Let's summarize what we just talked about. The use of 6 mils per kilo ideal body weight at the onset of mechanical ventilation will help to ensure the early delivery of lung protection in patients at risk, whether it's known by the bedside clinician or not, of developing ARDS. The evidence also just suggests that the patient is safe in the majority of mechanical ventilated patients. So that is kind of the summary of the pro outlook. And I think that's very, very important, right? Look at one side, the pro side. Now let's look at the con side. As we said in the very beginning, the premise that one prescription is good for all patients in all conditions on its own is difficult to sustain, right? We can't just say that 6 mils per kilo is going to be good for all patients. So let's look at this from the con side. Clinicians have adopted the practice of permissive hypercapnia to avoid lung injury. I think that's kind of a concept that we forget, that if we deliver a tidal volume that's lung protective, automatically we have to maintain a minute ventilation that is going to be able to sustain the patient. It's going to maintain their pH in the right range, right, based on your ventilation, your ability to blow off or hold on to CO2. And just by way of limiting our tidal volume, automatically your patients will become hypercapnic. So is that all right? When we think about that, however, clinicians must remember the effect of carbon dioxide is on different organs and organ systems, and how important CO2 is to specific conditions. We have to understand that, and we teach this all the time, acute hypercapnia leads to increase in cardiac output. This causes a secondary increase in contractility, increased heart rate, and this causes a reduction of SVR, systemic vascular resistance. So that's very important. We also have to remember the role it plays in our patients' vasodilation or vasoconstriction. And we see this all the time in the neuro population. So hypercapnia can be a big, big deal. What about if we're delivering a breath at a higher frequency? I kind of alluded to this earlier. If we're delivering a lower tidal volume and we're having to deliver a faster rate just to make sure we get that minute ventilation, we have to understand what that causes. It causes a possibility of auto PEEP. If we don't change the ventilator's I/E ratio to reflect our increased rate, our patients are going to become very uncomfortable, number one. That's not very comfortable. And we have to always remember to extend that exhalation time out. And if we don't, we're going to have a patient that's breath stacking, and that's going to increase auto PEEP, and that's going to have secondary negative effects on your lung compliance. You can have barotrauma, your plateau pressures will increase, and then think about what that does to all your vessels, your venous return. You can basically cause your patient to tamponade, and that's where you start seeing a patient that has a tidal volume going in of 500 mils, and then their exhale tidal volume slowly starts decreasing. And eventually, you're getting about half out of what you put in. Well, that's because all that volume is being trapped because we're not allowing for long enough exhalation. And all that starts with breathing too fast with a lower tidal volume. So we have to remember there may be patients that need that, and we're going to kind of evaluate that here at the end. But we have to account for that and manipulate the ventilator to allow for proper exhalation. So there's several determinants of gas exchange that we have to understand. We have to remember that partial pressure, right? That's Dalton's law. That carbon dioxide, lung perfusion. What's our alveolar surface area? We talk about this in the review class. Alveolar thickening. All that is based on the gas laws of Fick's law and Henry's law. What our hemoglobin levels are, what our tidal volume is, what our frequency is, our breath rate, and the overall dead space. All those things play into our decision to set a tidal volume and an overall minute ventilation. To better understand this and understand the effects of tidal volume, let's assume that we have a normal ABG, we have normal partial pressures, our lung perfusion is good, so we have no VQ mismatch. Our alveolar surface area is proper. We don't have any thickening, we don't have any mucus buildup around the alveolar membrane. So everything is good. So we would have a normal gas exchange. We have to also kind of take into the consideration of dead space. And I talk about dead space all the time, and this is the number one kind of forgotten thing about mechanical ventilation is we have dead space. And dead space really does play into our ability, our determination to start with a starting tidal volume. When we think about this, it becomes evident that to keep a minute ventilation constant, we have to have a tidal volume and a respiratory rate. Whether we use a low tidal volume and a high respiratory rate or a high tidal volume and a low respiratory rate, we have to maintain a minute ventilation that's going to be adequate for proper gas exchange. So if we consider that and we say, let's start with 6 mils per kilo ideal body weight for a patient with all the physiological values, alveolar surface area, perfusion, dead space, if those were all in normal limits, we would lose 2 mils per kilo in dead space. So essentially, only 4 mils per kilo is going to make it to the alveolar level. And that's where we kind of have to go back and remember that minute ventilation is one thing, but what is your alveolar minute ventilation? Now consider, what if you have a patient like a COPD patient, or even a patient that's got acute lung injury where your alveolar dead space is elevated? Or what about a sepsis patient or a metabolic acidosis patient where their metabolic demand is very high? The higher the metabolic demand, the higher the dead space, because we're going to have to breathe faster. If we've got to maintain a certain minute ventilation because our patient's pH is in the toilet, they're in a partially compensated metabolic acidosis, you automatically have to have a higher minute ventilation. And oftentimes, those patients are associated with ARDS or other pulmonary issues, and we automatically prescribe that lung protective tidal volume and that higher respiratory rate. Well, that also causes a bad effect. The faster we breathe, the more dead space we lose. That dead space gets trapped, and that actually can impede on our venous return, our cardiac output, and be detrimental hemodynamically. So if we think about this, if we increase the dead space by just 1 mil per kilo, the maximum minute ventilation that the ventilator can safely deliver basically decreases by 25%. So dead space, guys, is a big, big deal, and that's something to always consider when determining our starting tidal volume. Using conventional ventilation, attempting to ventilate the patient with small tidal volume values will lead to higher breathing frequencies and a development of hypoventilation. Intrinsic PEEP, right? That's that auto PEEP. It'll cause hemodynamic compromise and a higher worker breathing. So that's something that's real. That's a big deal. So what do we do? As I talked about in a previous podcast where I looked at the concept of driving pressure, that recent study of Amato et al. Used data from 9 randomized trials evaluating mechanical ventilation in ARDS to assess whether tidal volume normalized to a respiratory system compliance was a better predictor of injury. If you remember, they used a definition of compliance, the inverse of basically looking at plateau pressure minus the PEEP. So they used that as their guide. Tidal volume delivered above PEEP is the difference between your plateau pressure and the set PEEP, or what's called the driving pressure. So remember, tidal volume and static compliance, the difference between the two is the same as your plateau pressure minus your PEEP. So as such, that pressure difference in kind of looking at this evaluates total respiratory system compliance. The advantage is that pressure difference is an index of both a high tidal volume and a low compliance, each of which are associated with ventilator lung injury. The advantage of this is that pressure difference will give you an indication of either that high tidal volume or that high compliance. So in their thoughtful analysis, they evaluated that it probably is better as far as a best practice to utilize the difference between plateau pressure and your PEEP as a guide to, are we delivering the proper tidal volume, instead of utilizing that blanket kind of 6 mils per kilo or 8 mils per kilo. So more to the point, neither tidal volume or ideal body weight or plateau pressure had any predictive effect on survival or barotrauma. There was no difference in the relative risk of mortality at any level based on tidal volume or predicted body weight from 4 to 10 mils per kilo. It was based on driving pressure, and the driving pressure, remember, was anything less than 10, or anything less than 15. So anything less than 15 in an ARDS patient. Now, that doesn't mean we use driving pressure for all of our patients. That was very specifically looking at ARDS patients alone. So let's kind of summarize this. Let's summarize the con position. Their summary basically states, limiting tidal volume values to 6 mils per kilo of ideal body weight for all patients receiving mechanical ventilation has the potential to cause harm. The blanket application would lead to increased breathing frequencies, increased evidence of auto PEEP, potential hypoventilation, increased sedation, unmatched worker breathing. All these issues may be worth the price to prevent lung injury. That's a big one right there. However, new evidence on the understanding of lung injury suggests that the scaling of tidal volume to predictive body weight or ideal body weight is not an accurate way of predicting risk in the first place. That's what we're talking about with driving pressure. But again, remember, that was very specific to ARDS. Thus, the concept of limiting tidal volume to 6 mils per kilo needs to be re-examined in the face of the patient's condition, their overall disease process, and the physiological characteristics of their lungs. The simple tidal volume dosage for all patients may not be appropriate and may lead to harm in specific cases. First, new evidence suggests that there may be a better way to adjust our tidal volume values. However, more studies are needed before we could incorporate this into practice. We must keep in mind that the physiology and the multiple conditions often found in the ICU, also keeping in mind that there may be yet each situation where 6 mils per kilo ideal body weight may not be optimal. We also need to understand that the use of 6 mils per kilo ideal body weight does have the potential to increase hypercapnia, auto PEEP, and patient ventilator synchrony. However, these conditions are managed well at the bedside in the majority of cases. There are a couple of reasons to strongly consider the use of 6 mils per kilo ideal body weight in all patients as the institution of mechanical ventilation. The first is that pulmonary damage can happen in only a few hours after the initiation of mechanical ventilation with inappropriate settings. The second is that ARDS is frequently recognized after a delay in onset of the inflammatory process. Therefore, early use of 6 mils per kilo ideal body weight can be considered a preventive measure as opposed to a therapeutic modality. This may be especially protective in at-risk conditions such as sepsis, trauma, transfusions, or high-risk surgeries. Considering the evidence to date, it does seem prudent to use 6 mils per kilo at the initiation of mechanical ventilation. So to kind of summarize this in kind of my way of thinking is, I think that this is a phenomenal study. Again, it shows, and again, this is 17 pages. I just highlighted some of those main points. There are some patients that are going to need 8 mils per kilo, guys. Don't be afraid if you put a patient on the ventilator, and I talk about this in the previous podcast on whether to use pediatric BVM versus an adult BVM. Some patients may need 8 mils per kilo. That just may happen. If you identify that, don't be afraid to adjust your tidal volume. Just document why you're doing it. 6 mils per kilo may not work for everybody. Some patients may need 4 mils per kilo based on, their high plateau pressures. But that overall range is 4 to 8 mils per kilo. That's a pretty wide range. Don't get focused in and stuck on 6 mils per kilo. I think the evidence has shown that 6 mils per kilo is the perfect starting point. I definitely don't think there's evidence to say that there's 7 mils per kilo or 8 mils per kilo as a starting point. 6 mils per kilo is the starting point based on all the evidence. But don't be afraid to increase that if you identify that your patient needs a higher volume. Again, I want your thoughts on this. I will post this in the show notes. Remember, the show notes, you have to go to the website, www.FlightBridgeED.com, go to that podcast, and you'll see underneath, I'll have it published as a PDF. If you have any questions on this, email me at eric.bauer@FlightBridgeED.com. And until next time, I will talk to you soon.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.